when she gives me the. All right. Good morning, everyone. Thank you all for coming. I would like to call the meeting of Health and Human Services to order. The time is 10:32 on April 28th. Our first order of business is the approval of the minutes from the previous meeting. Are there any corrections to the minutes? No? Seeing none, the minutes are approved. The clerk call the roll, please.
Legislator Block.
Here.
Legislator Denton.
Here.
Legislator Burtis.
Here.
Legislator Kelly. Absent. And Chair Romeo.
Here. Legislator Kelly did inform us that he was unable to make it today. Our first order of business, we will be having substance. Let me make sure I get the title correct. Substance use initiatives presenting today. So thank you both for coming. If you could state your name, position, and present for us.
Sure. I'll lead in before I turn it over to Mariah Senecal-Riley, who's our Director of Substance Use Initiatives in the Health Department. I'm Katie Anderson, Commissioner of the Onondaga County Health Department, and glad for the chance to speak with you all today about our many different types of efforts in substance use, overdose prevention, harm reduction. And I think just for kind of laying out the landscape of this is an area of programming that I think really exemplifies the kind of work that we're increasingly trying to do, which is getting out of the civic center, getting out into the community, getting meeting people where they're at, and providing very responsive, prompt care. And you'll hear that exemplified in Mariah's presentation. So thank you.
Awesome, thank you. My name is Mariah Senecal-Riley. I'm the Director of Substance Use Initiatives. And I apologize, you have seen this presentation already.
It's okay. It's okay.
I'm just gonna run over all of our, I don't know if it's on or not. Thank you. Can you hear me now? Okay.
Yeah.
So I'm Mariah Senecal-Riley, Director of Substance Use Initiatives. I'm going to run over all the services present in my division. I've had the privilege of kind of building this over the last 9 years, really responsive to community need. I have someone in my own life who has struggled with substance use disorder for the past 2 decades, and a lot of these things that we've developed are things that I saw as gaps in seeking services for him. So we try still to be very involved in the community. I myself still do direct service when I can, just to make sure that we're keeping in touch with our clients' needs. Next slide. So I probably don't need to tell anyone this, but we've had a pretty significant overdose fatality crisis in Onondaga County over the last 14 years, but we have seen some really promising decreases in that over the last few years. You can see it peaked in 2021 with 186 deaths. But we've steadily seen a decrease, largely to what we think is the widespread distribution of naloxone, not just my own program, but other programs like Prevention Network, like Helio Health, ACR Health. We have really focused on getting that out into the community as widely as possible. So we really think that's what it is. Obviously, we can't attribute it to any one thing exactly, but when I first started, nowhere had Narcan. I used to have to beg people to let me train them, and now there are nalox boxes everywhere, and my health educators are doing multiple trainings a week in the community. So this is just the kind of bird's eye view of all of our programs. It started with our naloxone training, and our most recent effort is our case management services, but I'll get into more detail on that. So I just want to start with a foundation of all of our services are based around the concept of harm reduction, which is helping people to make the safest and healthiest choice for themselves at whatever point they're in their journey for recovery, whether that's active use or long-term sustained sobriety. We want to support them at any point in that journey and help them to be as healthy as they can with whatever point they're at. Like I said, we started with the naloxone training and distribution. When I first started out, I was just doing it for like county agencies. The first one ever was actually ski patrol at Highland Forest, and I had to really do a ton of outreach to get places to let me come. But especially over the last couple of years, we see private businesses, we see just general community groups. We also have an online training platform where people can take the training on their own. It's recorded, and they can do that without interacting with the person in case there's any stigma or their schedule doesn't allow for it. And we will send the naloxone in the mail to them, or they can pick it up, or we'll drop it off if it's within county. We also have a number of what are called nalox boxes, and those are like little lockers that are all over the county. We keep them stocked. They're at community agencies. They're at some public buildings. We have one at a laundromat. Anywhere where people might benefit from being able to access it on their own. Even though it is over the counter now, it's still pretty expensive for folks. So we try to make that as accessible as we can. In 2022, we began our syringe services program. At the time, we were the first county in New York State, like county agency, to do syringe services, which is a real like privilege, as we've helped kind of to guide that for other counties as they pursue that. We're what's called the second tier SSP, or syringe services program. And we have 7 locations within the community that we go to on a recurring basis. Like today is Tuesday, and we are at White Branch Library, and we're there every week at this time. So it makes it easy for our folks to know that we're going to be there. We're reliable. We do give out syringes, but that's like the tip of the iceberg for our mobile unit. We also do like immediate needs kind of stuff, like right now we're starting sunscreen, popsicles. We just ended hand warmers, gloves, hats. So again, very client driven. We try to be as responsive as possible. The last summer, someone was like, could you put water in a cooler for us instead of just handing out water bottles? And so the next time we went out, we did that. We also give out naloxone. We give out test strips from that vehicle. We have a peer, which is a person with lived experience who's certified in New York State, who goes with the unit to provide any sort of support that somebody might need, kind of direct them into appropriate services. But it's kind of like a little microcosm for as much as we can do for folks in that little 2-hour window where we're at the site. We also, just for you and your constituents, we do syringe cleanup and disposal. People can call us directly. You can send people to us. We will go out, do the cleanup, and make sure that they're disposed of properly. So I mentioned the peers. We are lucky to be funded by New York State OASIS to have a team of 4 CERPAs, or Certified Recovery Peer Advocates. They are all people who have gone through a certification process, and now they're what I call a professional friend. They're not case managers, but they're there for folks to have somebody to go with them to meetings, to appointments, to help them set goals. They're that kind of emotional support that a lot of our clientele don't have. Substance use is very isolating, so having somebody to walk along with them as they pursue positive change is really useful. Just recently, I was involved in a case where the client told me afterwards that our peer was the most supportive person she'd ever met in her life. So the work that they do is invaluable to our services. I don't think we would be as successful in engaging people in the other initiatives we have if we didn't have them. They do participate with our SSP, but they also do community sites like embedding, uh, primarily the library system. I mentioned White Branch. They're at Mundy sometimes, but also Emmaus on the south side, and we have someone at DSS. So we try to be places where people might need that additional support, and then once they're engaged with our staff person, we can help direct them to other services. So this is, I will say, my pride and joy. It's a substance use crisis response. It's very similar to what you might know as a mobile crisis team for mental health challenges. This team is staffed by peers as well, but we have developed a process to co-respond with the ambulance agency AMR. So if a call comes into AMR and they think that it could be substance use related, not just overdose, but if somebody seems like they're impaired, they will contact my team and they will go to the scene of the crisis and provide that support. Sometimes they'll go to the hospital with folks if that's what they need as like an advocacy and supportive person. That can be a really intimidating experience for some of our folks. So it's useful to them to have somebody go with them. But also just in the moment, a lot of people also choose not to go to the hospital. So they're there for when the EMS agency leaves. Our person is still there to talk with them, see if there's any barriers that they can assist with. My team is very active. A lot of the times we see people have multiple calls on them, sometimes even in a day, and they know a lot of our folks by name, which is really helpful as we redirect people to spaces where they're safer. They also give out naloxone. They give out those immediate needs supplies. We respond from other agencies as well as not just through AMR. Community members can call us. The mayor's office has called us before. County execs calls us sometimes, but also like other law enforcement agencies. We work with Centro. They call us directly if there's somebody there that looks like they need some assistance. So they're everywhere. They're doing great work. Like I mentioned, these are some of our partners. Syracuse Downtown Security is another frequent caller. We also work with probation, the Justice Center. Sometimes if we can catch somebody that we know is coming out, the team can intercept them. That's a little bit challenging, but we've had a couple really successful cases. It is from, it's only weekdays. It's from 8 a.m. to 7 p.m. We'd love at some point to be 24/7, but the 7 p.m. was a great growth point for us, just because a lot of stuff happens in the evenings. This is our most recent initiative. It's the Substance Use Support Services. It's a case management program. We have a couple different components of this. There's a service navigator that is someone, it's kind of like a point in time case management service. So if somebody just needs assistance filling out paperwork or they just need a birth certificate, that person can go in, kind of fly by night, do the whatever task it is, and then if they need longer term support, they'll move them on to our other case management levels or our peers or other agencies that have supportive services. The next thing is transition support. So that's really geared towards people leaving the hospital, leaving incarceration, leaving rehab or long-term residential. That's often one of the most vulnerable times for somebody when they come back into the community. They're at high risk for overdose. So having that support and again the peer, that's a very valuable entry point for our peers. That can help to mitigate that really high risk. That's a shorter term, and when I say short, I mean around 90 days. But we also don't ever close anyone from these. They just are kind of in inactive status. We don't shut the door on folks. If they need to come back to us for something else in the future, we're still there. The last thing, and I thought this was really important as I developed this, I've been doing behavioral health work for a long time, and when I started, it was when intensive case management was kind of being phased out. And that model is truly invaluable in that it's highly flexible. It can be, I need help learning to do laundry at the laundromat or how to balance a budget. But it also can be help with accessing resources. The long-term flexibility of the ICM model works really well for our clients, just because, like I mentioned before, a lot of the times these folks are highly isolated. So having this longer term circle of support is really invaluable throughout the recovery process. This is just a map of our outreach locations and our SSP locations. And again, SSP is Syringe Services Program. You might know that most of them are in the city of Syracuse. That is not intentional. We do have to be asked to go places. It's not always the most popular thing to have a mobile syringe services unit pop up in your parking lot. But we are very open to going anywhere in the community. We're not limited by city limits. So if there are other locations that need support or would be willing to host us, we're obviously very open to that. Any questions for me at this point?
Elaine, go ahead.
Yeah, so I am very familiar with a lot of the programs services that you're speaking to. One thing that I am not very familiar with are the nalox boxes. And I have some people asking me questions about these, but what are you finding that they are effective?
Like utilized?
Yes.
Yes. A lot of the times agencies will alert us when they need to be filled, but they get checked at least once a week and they often need to be refilled. There are obviously more high volume, high traffic locations, like we are with the Syracuse Peace Council. That one needs to be filled like every single week. There's ones that are in buildings, like we have some at some churches. Those are less often, but they are very highly utilized.
Are they like in parks too? Like, are they outside things, or
So the issue with naloxone is that it is temperature sensitive. So if it's frozen, you can't use it. It's a liquid, and then it doesn't do well at high heat for long periods of time. So we try to keep them in areas that are a little more sheltered from the elements, just for longer term stability of the drug. We're definitely open to having them in parks, but we would have to have that as a caveat.
Sure. My question around this too is, because I try to think of the positive with it, but I also think, I always look at the other side of things, is like there's user hesitation too, right? Like if somebody needs to have naloxone, like, maybe somebody isn't trained on it. So in situations like that where there might be, and oftentimes people use alone. So that was my question about, like my concern around these is how effective are they, because it kind of requires another person around that's willing to administer and help.
Yeah, we don't get a direct record of who takes them, because it is anonymous. We try to have it not be a barrier. There is a QR code for a training on the boxes that people can scan. We also have one on our website people can take. It is a nasal spray, and there are the directions on the box as well. So we try to give as many different avenues for people to learn, and it's not harmful if it's not an overdose. I don't know what to do about the problem of people using alone. That has been that's been something we've grappled with forever. But I will say that with the destigmatization of substance use, we hear about a lot less of that with fatalities where people were using alone, which I think that's a real positive change. Obviously, we would never want that to happen to anyone, but I think we're moving in the right direction.
I'll add as well, just to follow up on that. So Mariah's team, when you go out to community events and see the health department there, they're almost always there available to do naloxone training. And so you'll see all different types of folks from our community getting trained, which is really great. And they're also available to either go out, this is for people who may be viewing as well, to go out and do trainings, or there's videos on the website. So I think it's still a ways to go, but such a difference from when it first came out, and it was hard to get and expensive, and people wouldn't have known how to use it. So it's steady progress.
Yeah. So I'll say the new pumps that they have are just so easy. Can you talk about what that training involves? What kind of time commitment, or what they?
Oh,
Yeah.
I actually have it tacked on to this presentation.
All right.
So do you want me to do it very quickly?
So in 1 second, I just want to make sure we don't have other questions or statements. Legislator Denton.
So I just have a question about facilities. Like, what kind of facilities do we have for treatment here in Onondaga County?
So those are not things that our specific division oversees, but we're very resource rich. There's Helio has a number of facilities for co-occurring conditions. They don't just do substance use. They do mental health treatment as well. Kraus is a pillar and has been as a long-term like methadone provider. Syracuse Recovery Services, Conifer Park. There's Tully Hill. I know there's also a number of like private practitioners, like primary care, who do the Suboxone prescribing as well. So we are very, very lucky in that we have such a wide range of substance use treatment.
I know that at one time there was a wait list for beds. Is that something that we're still experiencing?
That depends on the week. So what we look for a lot of the time is detox for folks. And sometimes we can get you in right now, bring them. And then sometimes it's going to be a week. That's the most we hear of right now, which they used to be astronomically long, especially when somebody's seeking it right now. Obviously, that's our preference, that we would be able to get somebody in at the moment that they want it. But I've only heard about a week or next day.
Okay. Thank you. Legislator Burtis.
Thank you. Thank you, Doctor. Thank you, Mariah, for being here in the presentation. Got a long history myself with substance abuse knowledge and knowing people and being involved and supporting folks like in my father's kitchen and Road to Recovery. And so to look behind the veil is very sobering. Could you talk a little bit about naloxone and usage as far as what you're seeing, as far as where are we at? Is it high? Is it low year over year?
So you're not required to report the reversal. So we don't have a great picture of how many are actually utilized. What we do have is how often we're filling boxes, how often people are requesting it. And that is like, there are some locations for our nalox boxes that we're filling every week, and they hold 10 of them. So that suggests to us that they are being utilized. And we know we actually had a situation just a few weeks ago where a staff person passed someone who was in need on a sidewalk, and someone who was a passerby gave them a naloxone kit that we had actually given them at a different place. So the demand really suggests to us that they are being used very widely. I know that's not the most satisfying answer.
That's okay.
Well, I'll add to that as well. So I think if you look at that graph where overdose-related deaths were increasing, and then have decreased, which is a national trend, although we've beat the average here locally. There could be two explanations for that, right? It could be that use is down, or could be that use is the same, but we're preventing death.
Right.
And I believe that the data can be a little hard to triangulate, but it doesn't suggest that there's less drug use
Right.
around here.
That's the way it feels. And that was another one of my questions. We have the deaths data, but what about users? Is that up? Is it down? Is it standard? Specifically related to fentanyl, heroin, any breakout of any of that to give us an idea of where we are as a community as far as this type of heavy drug usage?
So for that, the information we have comes from New York State DOH, and there is a 2-year lag on that. Um, it does seem like more people are engaged in treatment. I think since our resources have expanded so much, it might not feel as noticeable because people get in so quickly. Um, but we don't have a great way to triangulate that, unfortunately. Um, what I will say from my team's reports, it looks like people are using less opioids. That's what we experienced with the crisis team. Most of the substance use crisis that we respond to are related to synthetic marijuana spike. And that's what a very large percentage of the people that we interact with in the community who are actively using are using. Most of them are polysubstance users, but that's because it's so inexpensive and easily accessible. That's what we see in majority of the folks using.
But do you think, doctor, too, that as people chase the high, they move from one to the other, and that's where we get into some deaths, and really as they go to harder drugs, and that they're not prepared for that, and then they get in trouble.
I think so. We're very fortunate for many reasons to have the medical examiner's office within the health department. Not all counties have that. Not all county health departments have that, and so we get a lot of really valuable information, particularly related to drug use, from the medical examiner's office. And one is overdose-related deaths. The other is they also test related to DUIs, DWIs, and so we can get information on people who are intoxicated but hadn't had a fatal outcome. And what that tells us is there's a lot of drugs that are mixed in what they are. So someone may think they're doing one thing, but they're actually doing multiple things. And that the doses of, say, fentanyl, for example, if you look at the amount in people's blood, it's been going up and up over time. We haven't yet seen what may come out that would replace fentanyl, just like in the graph that Mariah showed. Heroin was predominant 14 years ago. It's not anymore. It's fentanyl. We don't know what the next thing will be, but spike is certainly an emerging problem in our area.
Thank you.
Go ahead.
I know you were mentioning that we're only like till 7 p.m. and that maybe we would like to get to 24 hours. So I was curious, like on staffing, like where we are, and then potentially what would that look like to get to 24 hours?
So we are fully staffed for our crisis team right now to cover the 8 to 7 p.m.
Do you know how many people?
So we have 3 people. The third is in case someone is ill or out. And also almost our entire team is cross-trained on that. Even if somebody may not be actively working as a peer on our team, I think it's around 70% of our team are folks with lived experience and who have taken the peer training. So we all have similar skill sets. So we cross-train in case there's ever a situation. We had a moment a few months ago where we were very short-staffed and our whole team cycled in and out. So it would be unlikely that we would ever not be able to cover that shift. I would think that my preference is to have 2 people on at once. So I would think we would need at least 8 more people just for full time.
Thank you.
So my question is about the intensive care management that you had talked about kind of phasing off when you came in, and now you have that other form of case management that you're doing. Is what we're doing and able to do now similar to that intensive case management that was there before? Okay.
Yeah, very similar. So when I started working in behavioral health, it was 2013. So that was seen as very like resource intensive. We were moving towards health home care management, the care management model. And while that is very useful in linking people to resources, a lot of people need more hands-on support than that. So that was in the back of my mind during this whole time. And it is very successful with our clients. They get significantly more done because it is not a ICU twice a month, or even in some cases for care management, it's like the requirement is 2 phone calls a month. Our people need people in person. So having that flexibility and intensity makes all the difference in fast as fast as behavioral health system moves, progress for folks in connecting to services or whatever other goals they have, including like finding housing and things like that.
Great. One of the things you talked about is how many services are available here, and Legislator Burtis brought up some of the nonprofits that are talking. Are there collaborative meetings that are happening? What kind of coordination is happening there, and what's that look like?
Yeah, so I would, many of the behavioral health providers were all in many meetings together. So there's a ton of collaboration. We work very, very closely with the shelter system, but he mentioned In My Father's Kitchen, Road to Recovery. In My Father's Kitchen is involved in the Housing and Homeless Coalition, like outreach meetings, and so are we. It is a very collaborative community among providers. Road Recovery is not as involved, but they're not providing direct service. That's like a scholarship program. So we don't see them as often pop up, but it is significantly more collaborative than I think people would think among providers.
Yeah, because I understand how difficult it is just to make contact with people in continuous contact with regular appointments. So I know that a collaboration there would be helpful.
Yeah.
Are there other questions from legislators? Okay, so you can go to the next part.
Is that okay? Does everybody find with a very Narcan drink?
Yes.
So very fast, this is the abbreviated one that we do, but opioids are a pain relieving drug. You may know them by prescription names, oxycodone, but also things like fentanyl, heroin. What we do see, and this is a lot of our fatalities, are folks who are thinking they're using one substance, but it has fentanyl in it. That's the situation that we see most often. So even if somebody thinks that they're not using an opioid, they're at risk. So reasons that overdose happen, I mentioned that when folks get out of jail, rehab, long-term placement, their tolerance is significantly decreased. If they return to use at their former rate, their body is not able to handle that. Oftentimes also the drug supply has changed pretty significantly after placement. So they may think that they're getting one thing and it may be very different. Also, you mentioned using alone. That's always a risk factor. We see drugs packaged as one things and it being another. A lot of pressed pills that are marketed as like Xanax or Adderall, but it's actually like cornstarch and fentanyl. So when we think about risk for people who are not our like target population of opioid use, that's where we see a lot of high risk for folks. Also, if somebody has significant health conditions, a lot of our folks are at risk for hepatitis C. That can weaken the body and increase the risk for overdose. So Narcan is an opioid agonist. The way that it works is it blocks the pain receptors in your brain. It is short acting, 30 to 90 minutes. So we always encourage people to go to the hospital or be monitored for at least a couple hours afterwards. That doesn't always happen, but we encourage that because people could go back into an overdose, or sometimes we see because Narcan is an opioid agonist, it puts folks directly into withdrawal. So when that's a horrible state to be in. So they go and they seek more of a substance. So as the Narcan is wearing off, they have used more, so they're experiencing double. So we highly encourage people to go to the hospital, but realistically, that doesn't happen that often. It is safe for absolutely everybody. That's children, that's somebody that's pregnant, elderly person. It only works on opioids. So if what's happening to somebody is not an overdose, this isn't going to hurt them at all. Like if I used it on myself right now, it would do absolutely nothing. So if you think it might be an overdose, you might as well, because you're going to call 911 anyway. So things that we're looking for, the most important thing is unresponsiveness. We hear a lot of cases of people using Narcan on folks who are talking. You don't need to use Narcan on anybody who can respond to you, who is alert in any way. You can check for unresponsiveness by doing a sternal rub. So your sternum is here. You take your knuckles and grind them into it right on somebody's sternum. It hurts. So if they were able to respond, that would do it. We also say shake and shout if you're or if you're uncomfortable doing that. You don't have to touch somebody either, but see if they respond. They do not need Narcan if they respond in any way. They probably just have some substance use symptoms. Other things you may be looking for are like slow or no breathing. The skin tone might be different. A lot of times we see like a bluish or purplish tone. If somebody has darker skin, it could look grayish. They might sound like they're snoring, but the unresponsiveness is the thing that we want at all times for Narcan administration. So our quick run over, the first thing you're always going to do is call 911. Sometimes our 911 operators will walk you through it, which is a great moment for folks who may not have had a training. But also there are instructions on the box, and in the kits that we give out, there's a QR code if you were in the state of mind to do that. But it is very, very easy to use. What you would do, and sorry. What you're getting is a nasal spray. And this is not a blister pack. It's very easy. You peel off the back and you hold it in your hands like this. There is a red plunger here. Do not press up on this until it is in someone's nose. It is very tempting to do a test spray, but it's one and done. So you don't want to actually use this until you are administering it. What you will do with a person is you will gently tilt the head back, kind of open up the airway, and once that is done, you literally just put the tip of this in the nostril and press up. It doesn't have to be super far up there. For a long time, we were like, it does not have to be COVID test far. So as long as this is in the nose, you've done your administration. You wait 1 to 2 minutes. We used to say a little bit longer, but with fentanyl and how strong it is, we've really decreased the amount of time between doses. If you're comfortable in the kits that we give out, there are face shields, and you can do rescue breathing on the person. They protect you from another person's germs. Rescue breathing is a breath or 2 strong breaths and then a breath about every 5 seconds for 1 to 2 minutes. If you don't feel comfortable doing that, that is okay. You're still helping them. After that 2 minutes, you would take the other dose, because in every kit, you get 2 doses, and you always want to have 2 doses. So if you do an administration on somebody and you use 1 dose, please get a hold of us. We will supply you with a whole new kit. But you always want to have the 2. They may or may not wake up with 1 or 2. Because you've called 911, help is on the way. They will take over when they get there. If you are with somebody who has additional doses, you can give more than 2. It's not going to do anything bad to the person. So if after the 2 it doesn't work and Katie has her own kit, we can keep going with that process until EMS gets there. So if you don't remember anything else aside from only use this once it's in the nose, remember that it's safe to use on everybody. It's short acting, so we want to try to monitor somebody. You shouldn't keep it in your car because of that heat sensitivity. You don't want to be in a situation where it's frozen solid and you can't use the spray, and you also don't want it to be weaker than it's supposed to be. Everyone always asks this, am I protected from liability? Yes, in New York State, we have the 911 Good Samaritan law. So as long as you are trying to help somebody and not hurt them, and that includes administering Narcan, you are protected by law. There's a couple situations where you're not, and one of them is if there's an open warrant for your arrest. One is if it's a violation of your probation or parole. And then also if you have over 8 ounces of a controlled substance on you. And this is for you and the person that you're administering to. 8 ounces is quite a lot, so most people do not have that on them. Generally, that's indicated as intent to sell. But we were seeing situations, and this is not as common as it used to be, where there'd be groups of younger people, like high school, early 20s, at parties. Somebody would overdose and everyone would leave because they were scared of getting in trouble. And that's the intent of this law. It also protects in situations of underage drinking. That is all.
Awesome. Thank you very much for that.
Legislator Romeo, can I ask a quick question?
Yes, ma'am.
Are we or can we equip 911 with where these boxes are located so someone can access them when they call 911?
Yeah, absolutely. We work really closely with 911, so at our next meeting, I can talk to Commissioner Korn about that.
Any other legislators have questions? No?
I also brought Narcan for anybody that wants it.
Thank you. Just the last thing that I'll say, Mariah, like you had said, I'd seen this presentation. Thankfully, appreciate you doing it again for everybody here, and for the training. Your heart for this work and the effort that you've put into it, I really appreciate it. It's super important to me that we do this well, and I'm just thankful that you're there doing it for us. So thank you.
Thank you. I appreciate it. And soon our van will be fixed.
I look forward to going. Thank you both. Appreciate it.
You gonna leave it?
Yeah, we can keep.
Mine was in my truck, so.
The next item on our agenda is. Thank you. I turned it back on. The next item on our agenda is the Veteran Service Agency. I will let them introduce themselves so that they can give their title as well.
So I apologize. We don't have electronic copy. We did not send that over beforehand, so we have the folder. So I apologize, but we will send that to everybody. Sorry about
Got
that.
it.
I thought it was the smaller group and
That's okay.
the
This is our first
presentation,
month doing it, so
so-
we're getting used to it. Just Cena's very good at trying to make sure we're doing what we're supposed to do. So she's on top of us. It looks like your mics are on and green. Just please adjust them or talk into them when you're talking.
All right.
Right.
Jeez.
When you're ready, again, if you can introduce yourself and your title.
Now I can. Good morning. My name is Anne Marie Mancia. I'm the director of the Veteran Service Agency. I am a disabled combat veteran. I've been with the agency for 13 years. I was appointed director in February of 2020, and that is the same time that the agency was declared an independent agency. And this is Cindy Miley.
I am Cindy Miley. I am a military spouse. I am not a veteran, but I am a military spouse of over 33, going on 33 years. And both of my sons are currently serving. I am the first non-veteran to be appointed as assistant director to file and submit accredited claims in New York State. And I also do a lot of national and state advocacy for military family and veterans.
All right, thank you. So I always want to cover our mission. So our mission at the Veteran Service Agency is to assist veterans and their eligible dependents to apply for VA compensation, pension, and survivor's pension. The VA pension and survivor's pension are income-based benefits that are often applied for in conjunction with Medicaid. Application for VA pension and survivor pension is a requirement of New York State Medicaid, and that's only if the applicant is eligible. This is available to veterans and surviving spouses and eligible dependents of those who have served during wartime era only. We also help claimants navigate this process, often with deadlines that, if not met, could impact their Medicaid eligibility, and that's for the pension and the survivor pension. We also manage burial applications for the Onondaga County Veterans Memorial Cemetery, and that includes pre-burials and at-need burials. At this time, we have 7 positions and 3 to fill, and those are all helps positions, the ones that we have to fill. So right now, we have a director, assistant director. That's us two here. We have a senior veteran service officer and a veteran service officer on staff. We have 2 veteran service officers that are vacant positions and a veteran service aide. And as I said, those are all helps positions.
How long have they been vacant for? Or when do you plan on filling them? I guess is a better question because I'm more worried about going forward.
We're in the process. I'm
So
doing
the-
the
yeah,
we're in the
so
process.
we
of
are
doing
in the,
that.
we're always in the process of doing that, and that will unfold as we go through as to why
Okay.
that is. Yes.
Sorry.
Yep. That's okay. In 2022, we implemented VetPro, which is a new records management system, which allows us to upload our claims directly to VA and track them. This system has also given us the tools to track our progress and identify areas that need attention. In February of 25, we moved to the 11th floor, and now we have beautiful space with room for meetings, and each employee has their own work area now. Prior to that, we were on the 10th floor, and we actually had like 2 service officers in an office. We were with adult and long-term care, and we were in transition for several years. So as I said, in February of 25 is when we moved up to the 11th floor. We're always putting the mission first, and the Veteran Service Agency has placed VA claims processing at the forefront of our duties. The director and the assistant director are both accredited service officers, and we've maintained caseloads with VA compensation, pension, survivor pension, and VA claim burials. The passing of local law 1-2019, eliminating the burial fee. I'm sorry, so every time Cindy flips, you flip, I apologize for this. The passing of local law 1-2019, eliminating the burial fee at the Onondaga County Veterans Memorial Cemetery in 2019, generated an increase in pre-need burial applications that we continue to see today. So those are not the ones that are calling as the person passes. Those are pre-need. Those are reservations, if you will. And those, we continue to see probably roughly about a 200 a year that we're doing for pre-need. And that was directly impacted by that local law. The assistant director manages the burials and most of the claims that are associated with them. And this is due to the delicate nature of the cases and the experience needed to address the time-sensitive at-need burials. To streamline daily operations and focus on managerial duties, the director and assistant director have been shifting our caseload to the senior veteran service officer and the veteran service officer. This involves more than simply reassigning a claimant to another service officer. The transition requires multi-layered training, including monthly training from New York State Department of Veteran Services, oversight from experienced service officers, and continued communication among the team. And this kind of speaks to the staffing right now, because we need to be essentially prepared to receive. If we were to take on more staff during a time of transition, time has shown that that is not effective. We need to be able to properly train them and give them the time that they need to be successful. Otherwise, we're just going to continue to see a turnaround in service officers and burnout because they don't have the resources and we're not providing them the time that they deserve to learn the job itself. So you'll see in this graph, the shift of duties from 2022 to 2025 shown through the interactions, which are phone calls, emails, and in-person interactions, demonstrate the time required to make these changes. The focus here was to download the VA cases from the director to the senior VSO, which you can see was successfully done. And that's demonstrated just through that graph. But as we stated, that is very time consuming to do that. And it takes successful communication among the team and a lot of training. Outside factors play a large role in our day-to-day operations, to include changes in legislation and national trends in VA claim processing. VA signed legislation in 2022 that changed VA claims processing and VA healthcare eligibility for generations. And that was the PACT Act, and that was the largest VA healthcare eligibility increase actually to date. Veteran Benefit Administration final adjudications are averaging 84 days with uncomplicated cases. Most cases are complicated and will take upwards of 12 to 18 months. This graph here demonstrates the back pay that we have assisted our claimants in being awarded since we have been able to properly track these claims in VetPro. So that's why you can see in 2022, we didn't have all of the records to track those claims going back because it does take 12 to 18 months and sometimes longer. That's an average amount of time. There's many cases that can take years, and I recently just had one awarded that took 12 years. So it can take, many, many years to do this. But what this is showing is the significant impact that we have on the community. These are tax-free monthly benefits that are going into Onondaga County residents. In 2024, the Veteran Service Agency saw 549 clients in person. We averaged over 2,200 phone calls. The combined retroactive amount for these resulting claims was over $900,000. I think at that point it was about $977,000 that when we pulled that graph. Many of these claims were PACT Act related. And in 2025, we saw 400 clients in person, average 1,500 calls. To date, we have a combined retroactive amount for these resulting claims to be roughly 400,000. These numbers will increase significantly as these decisions are coming through. The VSA has assisted with ongoing renovations at the Onondaga County War Memorial. Operation Shadowbox continues to grow, highlighting veteran-friendly businesses and organizations in the community. These 54 shadow boxes are displayed throughout the War Memorial and provide a historic legacy to the importance of veterans in this community. The Veteran Service Agency led the planning, coordination, and execution with several veteran and military-related events, to include the Memorial Day ceremony at the Veterans Memorial Cemetery and the Veterans Day ceremony at the War Memorial. We assist with distribution of New York State Fresh Connect checks, which requires training and tracking. Since partnering with New York State Department of Veteran Services on this program, we have provided the community with $8,000 in Fresh Connect checks, and that was only over 2 years. We support local Guard and Reserve units with various outreach events and continuously work to strengthen those relationships. Staff have become sitting members of the CNY TAMS team, which is the Threat Assessment Management team, to bridge gaps in communication regarding justice-involved veterans' access to VA healthcare and VA benefits. The VSA participates in special events at Clear Path for Veterans. We help with planning of the CNY Veterans Expo and Parade and other organizations. The VSA continues to meet the increasing needs of our veteran community by expanding access to accredited veteran service officers, maintaining multiple accreditations, and increasing staff. Questions?
Thank you. Do legislators? I have questions. I'll ask my
Yes.
question.
No, you
You had talked about the staffing and how the training's intensive, and you were waiting on that. Maybe it said it in there, but I was trying to keep up.
Yes.
A timeline for that. Like when do you think you'll get to a point where that time's going to be
Yes,
appropriate?
So that's why I stress that they are helps positions right now. Prior to that, they were tested positions. We had to wait for a civil service test and then have one to pull those candidates from. The veteran service officer test on average was given every 5 years, and there wasn't an active test for several years for that. When we did hire from that test and we were able to get candidates in, the last test had 11 because there's not promotion for it. And then even when people do take that test, civil service law limits the people that are able to take it. It is at this time, active duty personnel are not considered veterans, so they're not eligible to take the test. So even with our Guard and Reserve community, if they're coming off of active duty, and we know that they're coming off of active duty, if it's April right now, and say we know somebody's retiring in July and the test is in July, they can't sit for that test at this time because they're not a veteran at the time to sign up for the test. So the test itself is very limiting, and that's how it always has been. So we didn't have a large pool of candidates, and when we would get people in, the job itself is very, very challenging, and you do have to have served in the military to be a service officer. Cindy was appointed. That's how that happened. But it's the job itself is very triggering. So as people get in and you get the training and you get the accreditation and you're learning, all of the policies, procedures, the rules and everything, and then you sit down and you start to get your own caseload, you're about a year in. So you're past that probationary period. We have invested resources into you. That's when everything kind of comes out. So that's when we need to be closer and doing left seat, right seat with those service officers, because now we're very concerned about that service officer. Are they going to be triggered? Are they okay to sit with that veteran, with that spouse, with, you know what I mean, to do that, because we want to make sure that we're giving that best service to the public. So it's not a body that's in that seat. It is a lot that's involved in filling these positions for longevity, because, as I said, time has told us that we have to be ready to receive those candidates. We have to be ready to have people to train them, which right now we do. That's why we have a senior veteran service officer. She is in charge of the claims team. She is in charge of the training. We are ready to receive. So probably the next time, you see us.
Okay.
Yes.
Yeah. So you're just going through the process right now. Like you're ready
Yes.
for it. You're just going through whatever kind of.
Absolutely.
Okay. Great.
Yes,
So we'll be
yes,
moving forward with that.
Yes. Yes.
Great. Questions from other legislator? Legislator Burtis.
Thank you. Thank you, Cindy and Anne Marie, for being here. Appreciate all your work on behalf of our brave men and women who have served. And through many conversations, I know that your veterans and the partners that you work with is very challenging, hard work, full of red tape, and it does take a long time in order to work with these folks, all of them, to get some of their challenges remedied. So I don't have a question. I just want to say thank you. And And I guess after the last meeting, I'm your newest board member, so
Oh, yeah.
there's that caveat.
Well, thank you.
I guess.
Go ahead.
So with you mentioned like a lot of your role is changes with different policy. I was wondering like with federal and state government, like how much does that impact you? Like, is there a time that like if a change happens at the federal level, do they give you time, or sometimes is it just instant?
It happens immediately.
Okay.
So I can speak to that.
Yeah.
When they overnight in DC, they passed. They were trying to pass legislation for medication and service connected disability. That happened overnight. That next day, we're immediately flooded with calls. So it's whatever is happening in real time to us. So we're always monitoring and reacting to whatever is happening in real time. So
When there is a government shutdown and active duty personnel are not getting paid, that's where, we're stepping in. That's real time that's happening.
which
So
is happening right now with
Yes.
our Coast Guard members up north of us, right? So a lot of them are civilian employees as well. With this shutdown happening, they're reaching out to us to find local support for, food insecurities and childcare and everything like that. So
that's where our community partners become so important. So we're going through and, bridging those gaps to see where the community can fill in here, because these benefits allow people to become eligible for VA healthcare, VA benefits. But the unfortunate misunderstanding is that all veterans are eligible for VA healthcare, and that is a large misunderstanding. A very small portion are actually eligible, and you have to go through the process to become eligible. So if you separate from the military, that doesn't necessarily mean that you can go right to the VA for healthcare. You have to be eligible. You have to have some type of service-connected disability, a low-income requirement, something along those lines, and that's the veteran. If you're talking about the spouse, very few times is a spouse considered in benefits. So that's where we need the community to come in and recognize that if somebody states that they're a veteran, or there's a veteran in the household, that, please don't turn them away and say, okay, VA's got you. That's not the case.
Thank you.
Mhm.
Legislator Black, do you have anything?
Thanks.
Okay. Yep. Legislator Bush.
Good morning. This is more an acknowledgement that I want to extend to you. As more towns have established the Veterans Outreach position, you folks have been a wonderful resource to those individuals, helping them learn the ropes, understand the program, and they are the front porch people that go to the veterans' homes and start the process that a lot of times ends up in your office to be completed. And it's a wonderful partnership that you've established, and it's a great, great resource for those folks. Thank you.
Thank you.
well, and we have to thank you because of that. You suggesting for that program, that's how it all established, with Annie and I building the framework for that to see what was needed in the community and how successful it could be in reaching them where they are at.
Yes.
So
Cindy started as a veteran outreach coordinator, and she was working with veterans in her area and was bringing the information to me. And then that's how
kind of develop
that-
where
yes.
that gap in service was, and where the education component to the public could be effective. So
Is that a formalized model across the county that you guys try to encourage municipalities to do, or is it just kind of a relationship?
no, we really encourage that framework, because if you don't do it right, the veteran is going to be affected. Their benefits could be impacted if they're not following the proper 38 CFR laws that we have to abide by. So we work really hard to try to work with the individuals that are appointed to the parameters of what they can and cannot do, and how we can work together.
It is a program that can be encouraged at the town level. Each municipality has the capability to do that within their budget through what is it, a resource,
It's an outreach position.
an outreach
Yeah.
position that's typically on their staff, but it's not a program that we are formally running, no.
Okay. So, but if municipalities wanted to look up what it was, they would be able to see, what it involves and what they would need, and be able to sign on to it. Like, yeah, okay. In your mission, it talks about families.
Yes.
Do you have somebody in your office that's able to dedicate their time to families of veterans in that? Because, I mean, it just seems like you need 3 more people. You probably need 10 more people.
Well, I think the most important thing here is that everybody remembers that our mission is claims. So, you know, with that, when we have somebody come in, typically with a claim, something has happened. They separated from the military. There was a death in the family. There was increase in symptoms of a service-connected condition. Something happened to bring them to our office. So when that happens, we work as a team. So we all have different experiences that we can bring to that. On our staff, I would say that Cindy does have the most experience as far as spousal benefits, reaching out into the community for that, having been, I'm a spouse too, but I always say I'm a veteran first.
Yeah.
But Cindy has accessed a lot of those benefits. So I would say a large majority of Cindy's time is that. So if I'm working on a veteran's claim and I'm working on the service connection for that veteran is going to obtain service connection and health care at the VA hospital. And if they just separated from the military, they came off of active duty, and neither one of them are working full time, they're transitioning, they're finding a home, that spouse is going to need some help. Those children, if they have children, they may need some help. So as I'm working on this part and working on the claim, that's where Cindy's going to be over here and talking with them. So yes, we do, but again, not formally, because this is also something that Sharon could do. It's also something that Scott can do. So we're all capable of helping the families and the spouses, but I would, yes, I would say,
Yeah. No.
the subject matter expert on that would
Yeah.
be Cindy.
I think we've
You talking to the
identified-
mic a little bit more.
Sorry. I think we've identified that with New York State, they now see that gap in services, especially with New York State having the most number of, and I'm speaking purely from the spouse side of air guard units in the state. So they've recognized that they are building programs as we speak for that,
Great.
and it really should be in New York State's lane to provide those programs directly for the families.
Okay, and
So
they're in the process of doing that. They don't have anything right now, correct?
they just did unroll a mental health space for the military spouses. So it's a dial-in twice a month. It's called Stress Be Gone. It is completely free resource. You can dial in. You get the self-help training, right? Because we all most normally put ourselves second. So they give you the training, and then it's the first Monday and the third Monday. So you get to go on for free. It's very confidential. If you want it to be, you can share your experiences, but it's so they've rolled that out, and then they're looking at some other programs as well. So they've stepped up and identified programs that they need to do.
Great. Any other questions, comments? Thank you both for everything that you do. We appreciate you coming today as well. So thank you for your time.
And we did include in here, next Friday, we're doing a cleanup day at the cemetery, and the Memorial Day ceremony flyers in there as well.
That's the end of our agenda for the Health and Human Services. Can I get a motion to adjourn?
Motion.
Second. Thank you.
It's nice
We're adjourned.
Likewise.